enjoyed working with Brian, putting this together probably more than anybody I've ever worked with, trying to get a program put together. He's wonderful and very efficient, and I wish he were like next door to me here, so it's no telling what we could get accomplished. But anyway, we've got some more stuff coming up for y'all in the months ahead, so yeah, we're looking forward to it. But anyway, without further ado, Brian Radford.
Thank you, Tracy. I'm going to be brief. I just wanted to tell you guys that we appreciate you having us tonight. I want to tell you about Dr. David Penberthy, the one who's going to be giving the presentation tonight in just a moment. But first, I wanted to tell you how we got to the relationship with Dr. Penberthy. Southside Regional Medical Center in Petersburg is a sister facility to Southern Virginia Regional Medical Center, and we work collaboratively on a lot of different fronts in healthcare on trying to provide more resources together to the communities of both Emporia and Petersburg respectively, and anywhere in between. So Dr. Penberthy's group, Virginia Radiation Oncology Associates, he's in private practice up in the Richmond, Petersburg area, Midlothian area, and they have 4 physicians that are part of his group. And about a year ago, actually 13 months ago to be exact, his first day with us was May 2nd, 2011. We wanted to bring a new group in to provide radiation oncology at our cancer center in Petersburg. And his group is a group that we decided to go with, and it has been an absolutely wonderful, we feel like it's been an absolutely wonderful decision that we made, and we, not the hospital, our patients have benefited greatly from this move, from this relationship that's developed. So, with that being said, I wanted to give you a little history of how this marriage, so to speak, came to be. I now want to tell you a little bit about our guest tonight. Dr. David Penberthy has been in the Richmond area practicing medicine for about 10 years. Prior to coming to Southside Regional, he was over in Midlothian with Chippenham and Johnston Willis Hospital System. Dr. Penberthy he got his undergraduate degree from Virginia Tech in electrical engineering. He then proceeded on to medical school at Medical College of Virginia. I guess a lot of us know it as VCU now. He then went on to serve in our armed forces. He was in the U.S. Navy, 4 years active duty, 8 years in the reserves, and during that time he did an internship while he was in the Navy, and he became a flight surgeon in the Navy. After leaving the Navy, the U.S. Navy, he went on to do his residency at the University of Virginia. And after finishing at University of Virginia with his residency, he went into private practice, which was the time period for the last 9 or 10 years that he's been in private practice. And then I love to affectionately tell people that he never stops. He has his love of learning, and he actually graduated with his MBA from, again, University of Virginia, Darden Graduate School of Business, which is a highly acclaimed graduate school. He got an MBA from UVA, another degree from UVA, just a year ago. So he's a great, great man, and our patients have loved working with him. And I'm going to go ahead and turn the microphone over to Dr. David Penberthy.
Well, thank you, Brian. I appreciate those kind words. Are there any Hokies out there? Yeah. All right. Any Wahoos out there? All right. I'm a conflicted individual. My wife's on faculty at the University of Virginia, and so, whenever UVA and Tech play in sports, we never know who to root for. So our daughter tries to split the difference. Well, I have some interesting things to talk to you about tonight. Oncology is a developing field like no other right now, and so technologies are emerging, indications are expanding for treatments. And so things that used to not be treatable are now being treated in a very effective manner. And I'm going to talk about some of those things. And so the topic of my talk is issues on oncology and state-of-the-art radiation treatment. I have nothing to disclose. This is how I make my living, but I don't have any stock in these companies that I'm going to be describing. But I do want to acknowledge some other physicians and physicists and nurses who have assisted with this presentation. I've given this presentation before to physician groups, and it's generally been pretty well received. But Dr. Sani is a neurosurgeon in Richmond. Dr. Strash is a medical physicist. Dr. Eichler is one of my partners in Richmond, and Faith Fleming is the Service Line Director for Oncology at Southside Regional. And they have helped greatly with this presentation. And specifically, what I'm going to talk to you tonight is a statement of the local cancer problem. And I'll show you some Virginia Department of Health statistics that are somewhat eye-opening. And then I'll talk about some interesting radiation technologies, accelerated partial breast irradiation, and some controversies surrounding that. I'll spend a lot of time talking about radiosurgery, and I'll also talk about external beam radiation. Whoops, let me go back. Both photons and protons. And some of you may be aware of this, but there's a new proton facility in the Hampton Roads area. And there's some data showing why that may be theoretically advantageous, but there's some limitations to that technology as well. But to highlight these issues, I'm going to talk about specific treatment of breast cancer, CNS is central nervous system tumors, so brain and spine tumors. And I'll talk about one interesting new development in the treatment of early stage lung cancer. And if there's any, is there a thoracic surgeon in the audience? Because he and I need to come up here and arm wrestle. Because thoracic surgeons have one way of treating it and radiation oncologists have another way. So these are statistics from the Virginia Department of Health, and this is in all of Virginia cancer incidence by health district. Now, Crater Health District is this district here with kind of shoe shape to it, and the dark shows a higher rate of cancer. Okay, so we live in an area that has high rates of cancer. Okay, now this graphic shows percentage of cancer cases diagnosed at a local stage. So you want high numbers here. So over here they're diagnosed at a high stage, at a local stage, meaning early stage, meaning more treatable. Where we are is very light, so more of the cancers are found at a later stage, which is not good. Then ultimately, this is, the crux of the matter. Cancer mortality rate by health district. And where we are, we have the highest mortality. So in summary, we have high cancer rates, it's found at an advanced stage, and we have high mortality. So I'm not the only one looking at this. The Department of Health is looking at this. MCD is looking at this. The governor's office is looking at this. If we don't do a better job of either treating or preventing cancer, somebody else will come in here and make waves. And we're trying to do our best to actually favorably change this in the state of Virginia. So this is just showing the radiation oncology catchment area. So a little bit different scale, but this overlaps with the Crater Health District. And PSA stands for Primary Service Area, and SSA is Secondary Service Area. So where I practice medicine is right smack dab in the middle of the area that needs it. So the need for the services exists. This is another graphic, a lot of detail here, but the bottom line is the highlighted areas show rates of cancer in different health districts for the top 5 cancers at least in the Crater Health District. And so breast cancer, lung cancer, prostate cancer, colorectal cancer, and cervical cancer. And this is unfortunate right here. In Crater Health District, we are #1 in the state for cervical cancer. Cervical cancer should have gone away. With the advent of the pap smear, people should have these things found at a very early stage, but unfortunately, it's being found at an advanced stage when it is much less treatable. And so this is what I consider more of an educational issue than anything else. And so we need to get the word out there that there are things to do besides treatment. We need to do better at prevention. And it's always easier to treat preventatively than treat after the fact. And look in Chesterfield, breast cancer, the highest rate in the state, right there in Chesterfield County. I'm going to switch gears. So that's a statement of the oncologic problem. Now I'm going to talk about some specific issues and some specific technologies that are near and dear to my heart. And if you think about what I do, I'm an electrical engineer by undergraduate training. Then I went to medical school. And then what I do every day is I use high technology to treat serious illness. So I think radiation oncology is a really interesting melding of the disciplines of science and engineering and medicine. And it's a really, how should I say this? It's a really wonderful discipline to be involved with. And it's undergoing tremendous change right now. I have this slide out here because Southside Regional Medical Center has had a cancer program for almost 3 decades. When the hospital brought me on, they said, would you help us get accredited? We want other people to know that we are doing state-of-the-art care. and we have never gone through the accreditation process before. I have never not worked in an accredited facility in the University of Virginia and in private practice, and I said, well, that sounds like an interesting project, so I enthusiastically embraced this, especially when I looked at the demographics in this area and where the need is. We can do the most good if we do good work here. And so I'm pleased to announce that in November 2011, we went through the first accreditation process and we got it. So the American College of Surgeons accredited us. And not only did they accredit us, but they actually gave us accreditation with commendation. And 105 out of 1,500 surveyed programs got the commendation. And so they looked at us, they saw we were doing good work, they gave us the stamp of approval, and so we feel very strongly about that, and we're starting to get the word out there that there's good service right here locally. Now, this is what I do every day. Available therapeutic radiation technologies. Most of what I do is external beam radiation. I do some radiosurgery, and I was the first in Richmond to do radiosurgery with the gamma knife. Brachytherapy is interstitial. It's placing radiation sources next to tumors. And radiopharmaceuticals are drugs that have radiation attached to them that may give a therapeutic benefit of some sort. I'll spend a lot of time speaking about these top three, less time talking about that. There are a variety of vendors out there, and each one provides all these pieces of equipment. These pieces of equipment are unbelievably expensive. A linear accelerator that Varian makes is about $1 million. A gamma knife that Electa makes is about $4 million. A proton therapy facility that IBA makes is about $140 million. And so there's huge capital investment to bring this technology to bear. But there's reason that we're doing it. Now, speaking about breast cancer issues, breast cancer is one of the mainstays of radiation therapy treatment, but it's actually an optional treatment. The majority of people that have a breast cancer need surgery, okay? Or everybody, you remove the tumor and then you do radiation if there's a reason to do it afterwards. And so the typical case, if somebody has a breast cancer and they select breast-conserving surgery, they would follow that with whole breast radiation for about 5.5 weeks. Then they would treat the surgical cavity for about 1 week. And the surgical cavity treatment is considered a boost treatment. The reason we do that boost treatment is studies have shown that that's the area at highest risk of recurrence. Well, people are taking that concept a little bit further and saying, well, if that's the area at highest risk of recurrence, why don't we just treat that? And so they've developed this technology called accelerated partial breast irradiation. And interest in this has actually exploded. There's an initial study out there that the data have matured to about 4 or 5 years that showed that it may be equivalent to standard radiation. Standard radiation has been given for about 30 years. So it has some advantages. Decreased treatment time. Everybody I know is incredibly busy. And so when I offer people, I have a 6.5 week treatment or I have a 1 week treatment, which would you prefer? Most people would prefer a 1 week treatment. There's also decreased radiation dose to uninvolved tissues. That's a huge theoretic advantage. The problem with these are, if it's decreased treatment time simply for convenience without the data to support its use, we have to be a little bit cautious with its utilization. If we are decreasing the radiation dose to uninvolved tissues, there may be occult areas of cancer which may exist outside the area that we're treating, which may be underdosed. And so we're waiting for all this data to mature. This is just showing you some graphics about techniques. This is called the mammocyte. You put a balloon into the surgical cavity, hook it up to a radiation machine, puts a radiation source in there, and so you treat from the inside out. This is an external beam radiation technique. This is intraoperative radiotherapy. And this is a technique where you put a lot of catheters through the breast. And so not everybody has a beautiful little surgical cavity. And we're fortunate in the city of Richmond that we have Dr. Doug Arthur, who's at MCV as a radiation oncologist, who's one of the world's experts in this technique. And so if you ever need that technique, we can call Dr. Arthur up and say, hey, I'd like you to see somebody. And he's always accommodating to us. There's also, this is another technique, the contour balloon, which has also some theoretic advantages with multiple lumens in here. I'm not going to go over all this detail, but I just want to show you that this is a clinical trial that's out there, R2G0413, and NSABP, National Surgical Adjuvant Breast and Bowel Project, B39. This is studying to see if partial breast irradiation is as good as standard radiation. Now, if you notice here, I'm going to point out one thing. You have to be an adult. Adult is defined as age over 18. Life expectancy of 10 years or more, and early stage breast cancer has all these other criteria. And then there are lots of reasons for people not being eligible. If tumors are large, if you have lots of positive lymph nodes. But this is a current clinical trial, and we're waiting for results. And so currently, we don't know if partial breast irradiation is as good as standard radiation. So the American Society of Breast Surgeons said, well, young people typically have more aggressive cancers. So if people are going to accept partial breast irradiation, we suggest that people are at least age 45, that they have small tumors and they have all these other criteria. So when Johnson Wales Hospital adopted the partial breast irradiation, we had debates in the medical staff, and we adopted the American Society of Breast Surgeons criteria. And so this was our selection criteria for people being treated off clinical trial. My specialty society, the American Society of Radiation Oncology, issued a consensus statement after about 4 or 5 years after partial breast irradiation was developed and out there. And the reason being is because at the time of the publication a couple of years ago, 32,000 women had received treatment with the Mammocyte. 32,000 women without a lot of data to support it. And they wanted to present guidance for patients and physicians for the use of this technology. And so they looked at all the published literature, and then they convened a task force. They looked at all the data and came up with the recommendations. And ultimately, they came up with 3 groups of people: suitable, cautionary group, and unsuitable. Suitable is a group for whom the APBI outside of a clinical trial is considered appropriate. Cautionary, proceed with caution. Unsuitable, probably don't do it. So if you notice here, the initial data was validated in women over 60 years old. American Society of Breast Surgeons said 45. So cautionary, women between 50 and 59. Unsuitable if you're younger than 50. They say don't do it. There's not enough data to support its use. So in conclusion, they say partial breast irradiation is an advent in radiation, and it is an emerging technology. So every person that I talk to about this particular technology, I say it's a new technology. Results may be equally as effective to standard radiation. It may be better, and it may be worse. We don't have the information yet to say whether or not it will. So we now have some criteria based on a specialty society about how we should adopt this. To add a little bit of controversy, so this is relatively fresh, December 2011, a group of doctors at MD Anderson, one of the world's leading oncologic institutions, studied every Medicare beneficiary that received partial breast irradiation in the Medicare database. And so they looked at, I think the number was 150,000 women. And the controversy was, 130,000 women. 4% of the patients who elected to have partial breast irradiation had a mastectomy, compared with 2.2% who had conventional whole breast irradiation. So their conclusion was, if you choose partial breast irradiation, you're twice as likely to need a mastectomy later on. And so MD Anderson does not treat people with that technology off clinical trial, but they are still using the clinical trial and still enrolling people. And it's interesting, we have colleagues at MCV, and they dispute these data and suggest that it's still appropriate. So Dr. Cutno and Dr. Arthur. And so it's an interesting controversy that's out there right now. Anybody have any questions regarding this? Okay. Now what about protons? Protons are particles. Photons are what we use for radiation treatment, and photons have the capacity to travel all the way through tissue, and the dose diminishes over time. So this line here is photon therapy. Protons, on the other hand, have a low entrance dose. This is depth in tissue, and then they kind of peak, and then they drop off. And And so you have a theoretic advantage to using protons. The problem is there are $140 million to have a proton facility, but we have one in the state of Virginia, and we're fortunate in that regard. So theoretic advantages: you can irradiate smaller volumes of tissue. Protons have the finite range, and then they don't have throughput to the dose. And they deposit all their dose in this area called the Bragg peak, and SOBP stands for spread out Bragg peak. And this is just an example, a graphic. When a radiation beam comes in using photons, the beam decreases with depth, but it passes all the way through. In protons, the beams actually deposit most of their dose, and then you don't get the pass-through. And so that's a huge advantage for things like pediatric tumors. For certain tumors around, this is in the area of the pituitary gland or in the periorbital region. But the bottom line with protons, there are some advantages. Tissue beyond the target receives very little to no radiation. I'm going to switch gears a little bit right now, and there's Elekta, which is a really interesting company developed by Lars Leksell, and I'll talk a little bit about him. But see how the proton dose falls out? There's another way to use photons. What if we use not just one beam here, but how about 2 beams? How about 3 beams or 4 beams? How about 192 beams? Elekta developed this technique called the radiosurgery. And the physician that actually developed it, his name is Lars Leksell. And he developed this external beam or radiation technique in which multiple beams of radiation are aimed at a discrete target, delivering a clinically significant dose of radiation while minimizing dose to the surrounding tissue. It's a one-time treatment. When we do radiation treatment for lung cancer or for a brain tumor, oftentimes it's 6 weeks of treatment, and there are reasons that we do that. But radiosurgery, it's a huge advantage. It's one time, and it's incredibly effective. Uses center-of-the-arc principle. So if this is the center of the arc, we call that the isocenter. And then we have beams coming in all from a hemispherical arrangement. And this is, so that would be the isocenter. This is one of the early collimators for the radiation beam. But you focus radiation here, you get a tremendous dose. And everywhere else, you get a very low dose of radiation, a clinically not significant dose of radiation. And we can use that for all sorts of things. But when Dr. Leksell, we talk about this new technology, and we developed this in Richmond. We got the Gamma Knife in 2004, and everybody was like amazed at our new technology. But look, Dr. Leksell developed it in 1968. So, that's 44 years ago. So it was developed a long, long time ago. When he started doing this, his neurosurgical colleagues thought he was a little bit out in left field, said, "What are you doing with these tumors? You need to be cutting them out." And he said, "No, I think we could just pack some radiation in there and have some effective results." By the end of his career and by the end of his life, he was lauded by governments for advancing the field of neurosurgery. And so this is the original, he's a Swedish neurosurgeon. They used to call this the Swedish hairdryer. Let me go back a little bit. This is the version that we originally got in 2004, and then in 2010, we got what's called the Gamma Knife Perfection. And so this is an absolute state-of-the-art machine, incredibly elegant, and it used the best, this couch can handle, I think the table limit, something like 550 pounds. They got it from the automotive industry, has sub-millimeter accuracy, and the ability to treat things is spectacular with this technology. The Gamma Knife is one elegant technology, but there are other technologies. And this is an example of a linear accelerator on a robotic arm. It's also known as the CyberKnife. Okay? And this is a standard linear accelerator which can be fitted with some attachments that allow us to do some stereotactic treatment. And this is what most community oncology centers have. And we have something very similar to that at Southside Regional. Let me talk a little bit about the process of stereotactic radiosurgery. When you're talking about treatment in something in the brain, you have to be incredibly accurate. And so we're within less than a millimeter accuracy, so sub-millimeter accuracy. Well, how do we do it? We literally bolt a frame to somebody's head. This is called a stereotactic head frame. And the they're anesthetizing this person's skin, and they'll literally put pins through there, pins pierce the skin, and go into the outer table of the skull, literally affixing that stereotactic head frame. And that stereotactic head frame you can't see here, but it has markings on here. You get an MRI scan with the stereotactic head frame in place, and the stereotactic head frame will have some channels in it that have copper sulfate, which shows up on the MRI scan, and so you can actually do three-dimensional treatment targeting. It's spectacular treatment, and it really is robotic and rocket science. So, and this is Dr. Sani, who actually brought the Gamma Knife to Richmond, and so he's looking at the treatment planning devices there. But what we do is we look at MRI scans, and then we see where the critical structure is, then we put dose around it, and then we treat it. And this is just a graphic, and this is a little bit dated now, but you get the idea of the trend. People are clamoring for this treatment because there are alternatives to the Gamma Knife treatment. You could have surgery. And let me ask you this, what would people prefer? An open craniotomy on one hand, which with the attendant surgical risk, the anesthetic risk, you'd have a stay in an ICU for a couple of days and a stay on the floor for a couple of days, but you're out of commission for the immediate period for a couple of days, and then the post-operative recovery lasts for an additional 6 weeks, thereabouts. Gamma Knife treatment is an outpatient procedure. You know, we take the frame off, we put Band-Aids on there, and we wrap the head so people look like they've been through a ward, and we want them to get as much sympathy with that head scarf as they can get. But it's really a wonderful outpatient treatment. And oftentimes when we treat people on the Thursday, we say, take Friday off and see how you're feeling Saturday. They get back to full activity very quickly. It's beautiful. So the indications for stereotactic radiosurgery. We can treat tumors, pituitary tumors, acoustic neuromas, meningiomas, metastatic tumors, gliomas, arteriovenous malformations, which are nests of vessels. We can treat people that have epileptic foci, seizures. We can treat trigeminal neuralgia, which is a terrible, painful condition of somebody's face. Psychosurgery. This is done outside of the U.S. If it's done in the U.S., it's done under experimental protocols. But I'll talk a little bit about brain metastases. And brain metastases, unfortunately, are incredibly common, and they're becoming more common because people are surviving with cancer longer. 34% of patients with lung cancer will develop brain tumors. 30% of patients with breast cancer will develop brain tumors. 72% of patients with malignant melanoma will develop brain tumors. And so we see this all the time. So this is just an example. Somebody with metastatic colon cancer. So we treat, one interesting thing is, I think this is an absolute beautiful example in American medicine of a multidisciplinary treatment approach to these terrible diseases, because I can't treat it myself. In America, for anybody to receive radiation, you have to have 3 professionals agree to the treatment and sign off on it. And so if I think somebody's a great candidate for this treatment, I have to convince 2 other professionals that they are a candidate for it, and anyone has a veto at any time. And so if we're all in agreement, the treatment goes forward. And so I like to say it's nearly doctor-proof. But before Gamma Knife, so this is an example of a metastatic deposit. You can see what it looks like before Gamma Knife. And 4 months later, it looks like this. You can't even see it. You have an option. People could have a craniotomy, a surgical resection, or you could have Gamma Knife, which is an outpatient procedure. And so more and more people are choosing Gamma Knife for these sorts of problems. This is an example of a big brain metastasis from somebody with lung cancer. Several months later, we don't see it. Hypernephroma is kidney cancer. So this is a critical area in the pons, in the central part where all the wires of the brain cross and go into the spinal cord. So that's not really surgically accessible. So this person in years past would get whole brain radiation, or they'd go to hospice. But we can now treat it with Gamma Knife, and then we see just a little wisp, a little remnant of it several months later, 1 year after Gamma Knife, in this critical area of the brain. It's incredible. So this is somebody we treated with lung cancer in December 2007. Then a couple of years later, or a year and a half later, we barely see it. And they're still here. They're still with us. And years ago, it was thought that if you had metastatic disease to the brain, that was it. You may not have many options. Now we have all sorts of options. This is a really interesting case, and this was, Dr. Sani and I like to talk about this being an emergent gamma knife. Rarely is gamma knife emergent, but this person's tumor was in an area called the foramen of Monroe where a lot of the CSF flows. And if you block off the CSF flow, the fluid that bathes the brain, you can develop some swelling and you can acutely check out of this world. And so we treated this person emergently, and then a couple months later we don't even see it. And so this is gamma knife, this is no incision, and the tumor is no longer there. Local control after radiosurgery of brain metastasis is independent of the type of tumor. It's called tumor histology. Surgery or survival does not depend on histology or number of tumors, but is related to the extent of extracranial disease. And this is for the Dr. Kanziolka, who is one of the leaders in this field, who is based out of UPMC, University of Pittsburgh Medical Center. We can also treat benign tumors, acoustic tumors, pituitary meningiomas. And this just shows you we identify a tumor, we put dose around the tumor, and then we can look at it in 3 dimensions. And this is, if I had the software to show you, we can rotate this all around and look to make sure that we're covering the tumor with the appropriate dose. This is somebody with, it's interesting, we qualify success differently compared to regular surgery. Surgery physically removes something. When you treat something with radiosurgery, you're packing energy into it, and then we assess the response based on the imaging characteristics. So this person had this. If you notice, it looks a little bit hollowed out. So the day of gamma knife procedure, it looks like this. 6 months later, it looks a little bit different in the central. It becomes more cystic, and then later it involutes. But this is a beautiful treatment, whereas somebody that had what's called a sphenoid wing meningioma before would have to have a cranial base operation, which is an incredibly challenging and difficult and operation for the patient, for the surgeon, for everybody. It's multiple hour surgery. Acoustic tumors. These are tumors in a part of the brain that's right next to the nerve that generates your hearing. Years ago, when surgeons would remove that, it was almost a foregone conclusion that people would lose the hearing on that side. People can still lose the hearing if they have gamma knife, and now there are better surgical techniques, and so fewer people are losing their hearing, but generally hearing preservation 50% of the time, facial nerve function being normal 99% of the time. It's incredibly cost effective. I saw one operative note from Dr. Sani, and it amazed me because he said the operation started at 7:30 in the morning and finished at 8 o'clock the next morning. So he's in there 24 and a half hours. Okay? So imagine the operative time, the anesthetic time, how difficult that is to recover from. Or there's an outpatient procedure that literally the treatment takes 30 minutes. The actual day of radiosurgery, somebody comes in the morning, they get an IV, and if they've signed all the papers, they start getting really good medicines, and so they're feeling no pain. But then they get the frame placed, which takes about 45 minutes. They get an MRI scan, which takes another 15 or 20 minutes. And then the bulk of the time that's uncertain is the treatment planning time. And I've seen the treatment planning time take 15 minutes. I've seen the treatment planning time take 6 hours. But while we're doing the treatment planning, developing the radiosurgery dose plan, the patient is with their family. They're comfortable there in a room. They still have the frame attached. Once we have developed the radiation dose plan and everybody's agreed to it and we sign off on it, they have their treatment, which goes very quickly. Then we take them out, take the frame off, wrap their head, and they go home. It's beautiful. And this is an example of very tightly conformed dose right around the acoustic neuroma. This is another one where the same kind of thing happens. These are fibrous tumors that are generally very slow growing, and when they're slow growing, they're slow to resolve. But several months later, after the gamma knife, it looks very different. And then generally later, if I had a picture to show you, it would be smaller. So we grade success by stability and shrinkage, whereas with surgery, you grade success by removal. Trigeminal nerve, you have 3 divisions of the trigeminal nerve, but this can cause an incredibly debilitating condition where people can't work, they can't function. And so we can treat this. The trigeminal nerve comes down to the base of brain in what's called the trigeminal cistern, which is just a space. And you have, whoops, let me see here. All right. the space, there's very little critical structures around there, and so we pack quite a bit of dose in there. And the Gamma Knife, this is a little bit of a side story, but the Gamma Knife got its name because the source of radiation in a Gamma Knife is a cobalt-60 radiation source. So it gives off gamma rays. And they thought it would actually burn or cut through tissue, so when they initially developed it, they called it a Gamma Knife. Well, the name kind of stuck. They found out later that it does not cut. It actually does biologically change the nerve or change whatever tissue you're treating, but it doesn't cut. But the Gamma Knife name stuck. So this is an example of showing that 4 months after the Gamma Knife, there's a little bit of enhancement in the nerve. And so one of the things, this nerve is a couple millimeters across. And so the dose is in an area 4 millimeters across. We have to be incredibly accurate with this. And that's why people have the frame bolted to their head. And when they get the Gamma Knife, it's secured into the head holder in a very precise position. It's Dr. Strash and Dr. Kuwafi. There are two medical physicists by which the whole program would not work without their input. But again, I want to emphasize that it's a team effort. No one person can do this by themselves. The physicists can't do it by themselves by law. The neurosurgeon can't do it by themselves by law. I can't do it by myself. When we all come together and it's the appropriate treatment, it goes beautifully. I'm going to switch gears, but this is interesting. I just said that the Gamma Knife radiosurgery, it has 40 years of data. So when we got ours in 2004, people were talking about, my goodness, this brand new technology, but it's not. It's been developed. There are hundreds and thousands of papers out there supporting its use. Well, people are saying, well, if the Gamma Knife works really well for the brain, if we see these brain tumors disappearing, why don't we do that elsewhere in the body? And we are doing that. And we have developed these other ways of doing stereotactic radiosurgery. And one of the things that is coming online recently is treatment of early stage lung cancer. And this for years was the purview of the thoracic surgeon. This is what they do. They remove tumors and can cure a lung cancer. Radiation can do the same, and it's much less morbid. But I want to have one word about screening for lung cancer. You're probably going to hear a lot about this. There's a study out there, National Lung Cancer Screening Trial, published in New England Journal of Medicine, which is one of the premier journals, showed that CT screening, as compared to a chest X-ray, resulted in a 20% decrease in lung cancer mortality in the group of people that they studied. And they studied people at high risk for having lung cancer. And those are people between the ages of 55 and 74 that have 30-plus pack year history of cigarette smoking. And the way we come up with that number is, it's pretty simple. We say, how many packs do you smoke a day? And they say, 1 or 2. And then, how many years have you smoked? And so if you smoke 1 pack for 30 years, that's 30 pack years. 2 packs for 15 years, that's 30 pack years. And so if you hit the criteria of, in that age range, that amount of cigarette smoking or more, the CT screening criteria are that you have a yearly CT scan for 3 years. And if you do that, your chances of having a lung cancer discovered are better, and the survival rates are better. Another aside, I was told that the breast cancer, the soon-to-be-coming ribbon, is pink. The lung cancer ribbon is clear, because they used to consider lung cancer the silent killer, because it was usually found with people with advanced stage lung cancer, stage 3 and stage 4, and we're doing our best to try to find it at earlier stages where it's much more treatable. This is interesting. This is a doctor, one of my colleagues in at Washington University in St. Louis, and he thinks that SBRT, another acronym, and I'll have a quiz for you later today, but stereotactic body radiotherapy. This is the technology that is dovetailing onto the Gamma Knife. So the Gamma Knife is specifically designed for the brain, and people have developed engineering techniques to do stereotactic elsewhere in the body. So this person thinks that stereotactic body radiotherapy should become the standard of care for stage 1 lung cancer. There are a variety of technologies that can accomplish this. That's a linear accelerator based. This is tomotherapy based. This is the CyberKnife. This is a proton facility. But again, stereotactic body radiation therapy, it's not really a machine, but a type of radiation delivery. Stereotactic just means it's the precise positioning of the target volume in all 3 dimensions. and we treat high doses per fraction, so we have to be very accurate with where we target it. And so the technology to make sure we're accurate has just expanded dramatically. And again, there are different ways of doing this with arcs, with, static fields, with protons. So with stereotactic body radiotherapy, the distinction between that and what we typically do, so for years, the standard of care, if somebody can have surgery for lung cancer, is you would have fractionated radiation. Fractionated radiation is every day, Monday through Friday, for about 6 or 7 weeks, a long time commitment. Stereotactic body radiotherapy, you have a high dose per fraction, it's less than or equal to 5 fractions, that's a Medicare rule. More potential for damage to the tumor, but also more potential damage to healthy tissue. You got to be careful about that. But you treat smaller treatment volumes and exploits this, what's called a geographic advantage of the precision and rapid dose fallout. So you treat the tumor, you don't worry about what else is out there. When I was in training for radiation oncology, you were taught that, well, where the tumor is, you have this microscopic extension beyond the tumor that you have to account for. So when we'd see a tumor that's, a couple of centimeters, our fields were much larger than that. Well, we're trying to narrow down the fields so we cause less collateral damage, so people live longer, happier, and healthier. In distinction, fractionated radiation, you get a low dose per fraction, you get many fractions, less potential damage for tumor, but also less potential damage to the healthy tissues. It's always the healthy tissues that are nearby that limit the dose of radiation that we can give. If you think about it, if we have tumors in a petri dish outside somebody, we can turn a radiation beam on all day and all night, and we can always get 100% cell kill. In somebody's body, though, we have to be very careful about the collateral damage to healthy tissue, and more people are living longer, and so they're concerned about the potential long-term effects of this. This just shows you, so this is the tumor right there, multiple fields come in, they don't have 192 beams of radiation coming in like the gamma knife can, but you have a very tight dose constraint right around the tumor. This just shows you, this person had the treatment in October 2009, there's the tumor. A couple months later, January 2010, there's the tumor. A year and a half later, a year and 9 months later, don't even see it. It's incredibly effective. And this person did not have to go through a thoracotomy. And so right now, more people are getting stereotactic body radiotherapy when they are not considered an operative candidate, because they have other issues. They have heart disease, or they're at risk to go under anesthesia. So they're considered medically inoperable. High-risk operable people still sometimes get a smaller surgery, and then medically operable people sometimes get a pretty big surgery, which can impair their ability to breathe. So we think that it's going to move a little bit more. So SBRT is used all the time in early stage lung cancer, and we think it's going to move into the other fields in the future as well. Now, a comparison, this is just kind of interesting. Comparison of the cost. These are all incredibly expensive procedures. So SBRT, $13,000 or $14,000. Surgery, where is that? Surgery, $15,000, and then if you get chemotherapy and follow-on radiation, it's doubles the cost of all of that. But they said that basically there's no difference in overall survival. Cancer-specific survival is identical, and SBRT may be a little bit less expensive. And you compare the toxicity. So with stereotactic body radiotherapy, you have all the typical radiation toxicities of skin, fatigue, chest wall irritation, inflammation of the lung called pneumonitis. You can damage some critical structures. You can have what's called a brachial plexopathy. It can cause bleeding. And so there's some areas that you cannot treat, and so not everybody is eligible for this treatment. Sometimes surgery is the best treatment out there. Surgery, you have the operative mortality. You could have death on the operating room table. There can be postoperative pain. There can be irritation to the heart causing atrial fibrillation. Extended hospital stays due to pneumonia or other problems after surgery. Sometimes people have a post-thoracotomy pain syndrome. Thoracotomies were once described as a very difficult surgery to recover from. techniques now at the time of surgery are much improved, so people have less postoperative pain, but sometimes the nerves just are irritated, and that can be a prolonged issue. So at least this one person's discussion was that stereotactic body radiotherapy should be the standard for people with medically inoperable stage 1 lung cancer. It is better than standard external beam radiation. And he thinks that it should become a standard for all patients with stage 1, because equivalent cancer-specific outcomes and controlled comparisons with surgery, no risk of the operative mortality, lower risk of overall toxicity, might be cheaper, depending. And then there are precedents to also show that radiation works where surgery used to be the predominant form of treatment, and one example is low-risk prostate cancer. I could have another hour-long talk about prostate cancer, because that's a little bit controversial right now with the recommendations that were just made by the U.S. Preventive Services Task Force, but that's a talk for another day. We'll have another meal on that one. But other indications for radiosurgery, people can have liver tumors treated, they can have spine tumors treated. One rule of thumb is that if somebody's had radiation, they can't have radiation again to the same area, but sometimes that rule is a little bit bent if somebody has the ability to have stereotactic radiosurgery, because you can protect some critical tissues a little bit better that way. But the list keeps expanding, and this is a burgeoning technology that is taking off like wildfire. And so more and more people are getting this done. In fact, a few years ago, we looked at the Medicare reimbursement rates for surgery versus radiosurgery with gamma knife, and the reimbursement rate for gamma knife radiosurgery went higher, where the surgery rate went lower. And we think that, and I haven't spoken to anybody at Medicare to verify this, so this is pure speculation on my part, but I think they were encouraging the use of that technology because people did not have the hospital stay, they were back to work, back to functionality quicker, and they didn't have all the surgical complications. But it's a spectacular technology. And that concludes my talk. And the next time we need to be at the beach, especially on a beautiful, summer day like today. Does anybody have any questions? All right. I appreciate your time. Enjoy your
right
meeting.
here.
Oh. Yes, ma'am.
What about preventative ways in your diet to try to help prevent cancer?
I have a magazine to show you that I brought. Brian has. Is it right over here, Brian? American Cancer Society has, all of these treatments are wonderful. The best way to go about life, though, is to avoid needing any of these treatments. And so prevention is the key. And so what we know... Live your life as healthy as you know how. If you're overweight or have more calories, you're at higher risk of developing cancer. So diet is critical. A healthy lifestyle of being less sedentary, being more active. And there's this is a journal from the American Cancer Society that's talking exactly about this. So guidelines on nutrition and physical activity for cancer prevention is right here. And it's lengthy, but there are lots of effort in that regard to prevent cancer from occurring in the first place.
Why is spicy food bad for you?
It's not bad for everybody, but the one rule is any sort of material that's a constant, ongoing irritant to tissues may induce cellular changes that can lead to problems. And cigarette smoking is the best to describe one of those because it's an irritant and it causes changes, and then sometimes your body repairs those changes and sometimes it does not. Spicy food may be an irritant to some people's mucosal membranes and may also lead to problems. But I don't know of any specific data that says you can't have any spicy food. And I'd be in trouble.
Well, the reason why I asked because I had a girlfriend and she would take like healthy food. And the stuff would be really too spicy. And she ended up dying from breast cancer. And as far as I know, she had no history of breast cancer in her family. And she didn't even live to be 40.
Well, and that's unfortunate. So I'm sorry for your loss. But sometimes cancers happen for reasons that we don't know. Anybody's at risk of it. We know some behaviors can increase the risk of certain types of cancer, and I don't know of any relationship between spicy food and breast cancer per se. But when it does, when breast cancer happens in younger women, it's typically a little bit more aggressive.
Well, I know one thing, she was skinny all her life, but she ate terrible.
Do we have any other questions for Dr. Penberthy? Okay, we have, Brian, did you want to talk about some information we have up here for?
Thank you all for your time.
Thank you.
Just a little information about our oncology program. We're just going to put these over on the side table.